I think it's important to realize that cancer is a disease of your DNA. And so in lung cancer, particularly non-small cell lung cancer, the DNA needs to undergo interrogation because there may be changes in the DNA, either mutations, which are alterations of genes that create altered proteins, or translocations in genes that also create altered proteins. And many of these proteins can be important in driving the cancer to grow. Typically we test the biopsy material, so it's important to get enough of the biopsy material to test, but technology is bringing us the ability to test many of these things in blood nowadays, so that's another option. The things that I would absolutely want to know that my doctor knew about was, do I have an EGFR mutation, an ALK or a ROS1 translocation, a BRAF mutation, alterations in the MET protein, either amplification or mutation in that setting, RET, HER2. So there are a number of things that I think patients should be asking about, because these can potentially change the course of your disease, not only from the prognosis, i.e. how well you're going to do, how long you may live, but also direct you to the right therapy. This is, lung cancer in 2017 is not a one-size-fits-all. Every case is an individual case. And even though there may be similarities between cases, each patient's lung cancer may be different than the next patient's lung cancer. So the way to do that is to look for these alterations in the DNA that may have a huge impact on prognosis as well as treatment approach.
So now if we're staged, we have a diagnosis, and we've done our scans, we need to do biomarkers. These biomarkers are these markers that, again, reflect what's in the cancer and what potential therapy we can match with it. So the ones we like to do are EGFR mutation, that's epidermal growth factor receptor mutation, ALK, anaplastic lymphoma kinase, as well as ROS1. And those are reserved mostly for our non-squamous diagnoses, but also PDL1, programmed death ligand 1, which tells us if immunotherapy is the appropriate choice for initial therapy. So that's really part of what we have to discuss, is what now, based on all the information that we've gathered, or if we need other information, what is the appropriate therapy? Is it going to be an intravenous drug? Is it going to be an oral drug? Is it going to be a targeted drug? Or is it going to be a non-targeted drug?
The process of molecular testing does take some time, depending upon what or how you may be testing it. It can be anywhere, for some of the tests, a week, to some of the more complicated tests, 2 to 3 weeks. In certain situations, patients are well enough and they don't have findings that are really threatening to them that you can wait, although we all understand that that's very anxiety-provoking. In many instances, when you have a sick patient that needs to be treated, then the current paradigm really is to use standard chemotherapy until you know the results of the molecular testing. Again, there are many patients who a doctor may feel uncomfortable waiting 3 weeks for the results of tests. You can start with chemotherapy. It doesn't mean you can't alter the choice of therapy if you find out that there was something detected on the molecular testing aspect of it. So there's complete flexibility depending on the results. But if you're sick, you need to get treatment.